Chapter 25, Fluid, Electrolyte, and Acid-Base Balance. These are the theory objectives for this section of the chapter. Okay, so more than half the body's weight is water, and it varies how much depending on your age, your sex, your health status. As you get older, your body tends to lose um, more fluid. Your body loses more of the water. And so infants and elderly are actually um, uh, can become dehydrated more quickly than your healthy young adults. um, Water is has several different functions. Um, Lots of different things in the body depend on the water in the body. Water is critical in maintaining homeostasis. Four main functions of water in the body. It serves as a vehicle for transporting substances to and from the cells. It helps with heat regulation in the body. It helps to maintain the hydrogen balance in the body. And it helps with enzymatic action for digestion, helping to digest foods and things like that. So lots of different things in the body depend on uh, water, right? You can uh, survive a week, maybe more, without food, but you wouldn't be able to survive more than 2 to 3 days without water. You have to have water to continue to maintain. Okay, the amount of fluid your body is putting out should be comparable to the amount of fluid that you're taking in. And so different ways you take in water, uh, orally, by drinking it, um, food, certain foods that you eat, your fruits have water, so different foods that you eat, and metabolism. So your normal healthy adult should take in um, between 2,000 to 2,500 mLs a day. And output, different ways we can excrete fluids through your urine, obviously, um, your urine, um, perspiring, your feces, your expired air. So when you exhale, right? So those are insensible water losses, like your perspiration, your expired air. Those are things you can't measure, but we can measure your urine output, your feces, especially like if you have diarrhea or something like that. If you have wounds that are draining a lot, those are ways you could be losing fluid as well. Vomiting, those are different ways we're losing fluids. If you're excessively vomiting, burns, if you're hemorrhaging, surgical sites, those are ways that we could be losing fluid. And so if we're losing more fluid than we're putting in or not taking in enough fluid, we can become dehydrated. And we'll talk about that here shortly. Okay, electrolytes are electronically charged minerals that are found inside and outside the cells of the body. And so they're ingested um, by the fluids we take in, by the foods that we eat, and they're primarily eliminated through the kidneys, although they can be eliminated through the liver, skin, and the lungs to a smaller degree. So we have several electrolytes um, that we need to, be mindful of. Your sodium, potassium, calcium, magnesium, phosphate, chloride, and bicarbonate. Your sodium, now um, dependent on where you look, the lab values may be slightly different by one or two numbers or whatnot, different depending on different sources and what they might say. But sodium is your major extracellular um, ion, and it helps with water regulation and balance. And a normal sodium is 135 to 145. You need to know your lab values. You need to make sure from here on out, you need to understand what your normal lab values are, what each of these things do for the body, and what can happen, what might you see in your patient if these things are off balance. Your potassium helps with nerve impulse transmission, muscle contractions, acid-base balance, normal heart rhythm. So if it's off, then you could have dysrhythmias with potassium. And a normal potassium is 3.5 to 5.0. Calcium helps with muscle activity, bone coagulation, um, so, bone structure, neuromuscular function, things like that, blood clotting also. And a normal calcium is 8.4 to 10.6. Magnesium helps with nerve impulse transmission and muscle contraction also. And so a normal magnesium is 1.3 to 2.1. Oh, going back up, I know I said sodium was the major extracellular cation, but potassium is the major intracellular ion. Phosphate, um, phosphate helps with ATP production, which stores and transmit chemical energy within the cells. And a normal it also helps with some acid-base balance too. A normal phosphate is 2.7 to 4.5. And chloride also helps with acid-base balance. And so a normal chloride is 96 to 106. And then your bicarbonate helps with acid-base balance, and a normal bicarbonate is 22 to 26. Okay, so body fluids are contained in two primary components that are separated by a semi-permeable membrane. The two compartments are referred to as intracellular and extracellular compartments. About 65% of the body's fluids are contained inside the cells, which is called intracellular. And the remaining 35% of the body fluids is located outside the cell, which is called extracellular fluid. So the extracellular compartments are further broken down into three subdivisions: interstitial, intravascular, and transcellular. So interstitial fluid is fluid that's between the cells and around the blood vessels. So surround the spaces surrounding the cells. So that's about 25%. Intravascular fluid is fluid that's inside the blood vessels. That's also called the blood plasma, and that's about 8%. And then transcellular fluid is fluid that's in the eyes, the saliva, the cerebral spinal fluid, um, uh, uh, GI, all those things are transcellular. Okay, so and as I said before, your major extracellular ion is sodium, and your major intracellular ion is potassium. So if something causes a major shift of the intravascular fluid to the interstitial space, such as vomiting or something like that, then you'll have a decrease in your blood pressure. Okay, so fluid volume deficit, as a deficiency in the body fluids. And so it's caused by either um, not taking in enough fluids or losing an excessive amount of fluids. And so a lot of things can contribute to not taking in enough fluids or inadequate intake of fluids, such as the inability to swallow or chew. If they can't swallow or chew, then they're not going to be taking in fluids that they need. The inability to self-feed, right? Same rationale, because then they won't be taking in enough um, if they don't have, anybody to assist them and they can't do it themselves. Lack of access to clean water or food, anorexia meaning just simply they're not eating, maybe from illness or whatever, nausea, so that's going to prevent them from taking in enough fluids. People with confusion or dementia, they may forget to take in enough fluids. Weakness, they don't have the ability to take in enough, them, themselves, but if they're so weak. um, on the other hand, excessive fluid loss may occur when there is vomiting, diarrhea, bleeding, so you're hemorrhaging out, overuse of diuretics, making you urinate a lot, trauma to the kidneys or kidney diseases, um, you know, uh, wounds that are draining excessively, all these things, excessive illness, and you have excessive sweating. These are all things that can lead to dehydration. And so for dehydration, um, which we'll talk about in a moment, what are some of the signs and symptoms of dehydration? But um, that's what happens when you have fluid volume deficit. Okay, so these are just some signs and symptoms of a person that's experiencing dehydration. Um, Maybe they have excessive thirst, they're going to be weak, if they don't have enough, fluid in the body. And so dizziness, decreased urine output, cracked lips, dry mucous membranes, thick saliva, dry scaly skin, poor skin turgor. Poor skin turgor is when you pinch up the skin and between your fingers. If the skin stays pinched, then that could be a sign of dehydration. It should bounce back to its uh, uh, normal turgor. Flat neck veins, decreased blood pressure. Anytime you have a decrease in the fluid volume in the body or decreased cardiac output or something like that, your blood pressure is going to decrease. Your blood pressure can be directly related to the fluid volume in the body. So if the fluid volume in the body decreases, the blood pressure is going to decrease and the heart rate is going to increase. They could also have increase in their temperature as well. And so people that are dehydrated, we have to increase their fluid intake, but maybe they're so dehydrated that just taking in fluids is not enough and they might need IV fluids as well to improve their fluid volume in the body. But you need fluid intake, increase their fluids. Okay, fluid volume excess is basically fluid overload, and it's caused by an excessive intake um, of fluid or decreased excretion of fluids. So you're not excreting enough fluids or you're taking in too many fluids. And so excessive intake of oral fluids is a rare occurrence, but it can happen. Most cases of excessive intake of fluids are related to infusion of excessive amount of IV fluids. And so some things that can lead to um, a decreased excretion of fluids, maybe like cardiac failure, like you have heart failure or renal disease, some types of endocrine disease like syndrome of inappropriate antidiuretic hormone, um, excessive sodium intake um, can also cause fluid volume overload. Sometimes given tap enemas can also lead to uh, fluid volume overload as well. So some signs and symptoms of fluid volume excess would be weight gain, crackles in the lungs, a slow bounding pulse. And so remember, I told you your blood pressure tends to follow the fluid volume in the body. So if you have an increase in fluid volume in the body, your blood pressure is going to increase. Possibly edema. So edema, pitting edema specifically is if your patient has edema and you press in and you leave an indentation, it would be considered pitting. If it doesn't leave an indentation, then it's non-pitting. But the degree of how long the indentation lasts and how deep the indentation lasts will determine is it +1, +2, +3, +4. There's actually a picture in your book, figure 25.4, that shows you what edema would look like. Because you have the crackles, you could have dyspnea, um, uh, jugular vein distension could be another sign. Lethargy, depending on how bad the fluid volume excess or overload might be. Irritability, confusion, seizures are all indications of fluid volume excess or fluid volume overload. So our interventions for a person with fluid volume excess or fluid volume overload, obviously we're going to monitor the intake and output, and we're going to do daily weights, and weights should be taken every morning before breakfast after the patient voids, in the same amount of clothing on the same scale to get an accurate weight on that individual. They may need diuretics to help excrete some of that fluid. Maybe they need a sodium restriction. Water follows sodium. So we want to restrict our sodium intake, and then making sure you're educating your patient on what types of things to avoid if they have a decreased sodium diet, such as canned foods, processed foods, that's anything that you could just put in a microwave and go. Lunch meats, hot dogs, all those things. Make sure you're educating them on reading their labels, because those things can increase uh, fluid volume in the body. They may need a fluid restriction as well, restricting the fluids as well. Okay, so sodium. We said sodium was for water regulation and balance. And so get used to different prefixes and suffixes that can help you to define what different words mean. If you see hypo in front of something, that means decrease or less than. If you see hyper in front of something, that means increase or more than. So we said a normal sodium was 135 to 145. So hyponatremia would be a sodium level of less than 135. Hypernatremia would be a sodium level of more than 145. So some things that can cause a person to have hyponatremia. So whatever's causing you to have decreased sodium, or increase in water intake, or retention of water. So anorexia, heart failure, burns, tap water enemas, cirrhosis, syndrome of inappropriate antidiuretic hormone, which is an endocrine disorder, renal disease, increased water intake, things like that. And so hyponatremia, you might see the person have altered level of consciousness, anxiety, nausea, vomiting, headaches, tiredness, dry mucous membranes. They might have nausea, vomiting, abdominal cramping, dry, pale skin. They might be disoriented, have muscle cramps or muscle weakness, tachycardia, and seizures. So things you're going to do is obviously monitor INOs, monitor their weights. They might need IV fluids. We're going to restrict free water intake, monitor for excessive fluid and sodium intake, monitor their labs, monitor their neurologic status, and put some seizure precautions in place as well. Hypernatremia can be caused by another endocrine disorder, diabetes insipidus, which is going to cause polyuria and have excessive fluid uh, deficit with that. Um, a high intake of sodium, nausea, diarrhea, vomiting, diarrhea, increased water loss, excessive sweating, things like that. And so the person, because this person could be dehydrated, they might have excessive thirst, dry, flushed skin, sticky tongue or mucous membranes, a fever, nausea, vomiting, anorexia, polyuria, which is excessive urination, tachycardic, neurologic issues such as restlessness, irritability, agitation, confusion, seizures. So for this person, again, we're probably going to be monitoring INOs and monitoring weight, verify fluid orders that they might have, um, also infusing fluids as prescribed. You want to avoid overhydrating the patient and implementing your seizure precautions and monitoring neurologic status and provide oral hygiene care for the patient. So your potassium, we said helps with nerves, functions, muscle contractions, helps the heartbeat stay regular, um, things like that. Acid-base balance, and we said a normal potassium level was 3.5 to 5. So hypokalemia would be a potassium less than 3.5, and hyperkalemia would be a potassium greater than 5. And so for these individuals, people that might be at risk, people with a poor diet, if they have vomiting, diarrhea, excessive sweating, or diuretic therapy, things like that. And so you might see these people have abdominal pain, cardiac dysrhythmias for hypokalemia, cardiac dysrhythmias, um, urinary retention, confusion, tiredness, constipation, um, increased respirations, increased heart rate, like I said, the dysrhythmias and things like that. So they're going to need oral potassium replacement, maybe IV with potassium in it. um, Patient teaching on potassium-rich foods, monitor their pulse rates, monitor EKG changes, things like that. And then hyperkalemia, so a potassium level greater than 5. So people at risk for hyperkalemia might be people with uncontrolled diabetes, renal failure, people that's taking potassium-sparing diuretics, um, uh, excessively taking potassium supplements, people with burns or chemotherapy, things like that, people with acidosis. So you might see these people might have weakness, paralysis, hypotension. They might also have some EKG changes and dysrhythmias as well, diarrhea, irritability. So for these people, we want to caution the patient against salt substitute uses, monitor their INOs, restrict the oral and IV potassium intake. Um, you want to monitor their EKG changes, monitor their vital signs, things like that. Okay, so your calcium again helps with muscle activity, blood coagulation, things like that. So we said the normal was 8.4 to 10.6. So hypocalcemia was less than 8.4, and hypercalcemia was greater than 10.6. Things that might cause you to have hypocalcememia. Nutritional deficits of calcium or vitamin D um, uh, it can cause it. Um, So vitamin D deficiencies, inadequate dietary intake, hypoparathyroidism, alcoholism, renal disease, pancreatitis, those kind of things can cause it. Some things you might see in this person might be tetany or muscle twitching or things like that, seizures, irritability. You might see Chevestek sign, which is when you're tapping along the side of the face, and then the person starts to have muscle twitching in the face, or trousseau sign, when you put that blood pressure cuff on and pump it up 20 millimeters of mercury or more above the systolic, then you get a twitching in the wrist. Um, Paresthesis, numbness, tingling are things you might see. So for these people, you're obviously going to do patient teaching regarding at, and at, about adequate intake of calcium. And so they're going to probably have some IV calcium ordered. Sunlight exposure can be helpful, monitor their vital signs, and things like that. Hypercalcium would be a calcium level greater than 10.6. And so some things that might cause hypercalcemia would be the hyperparathyroidism, um, cancer, excessive intake of calcium could cause it, prolonged immobilization, osteoporosis, steroid therapy can cause it. So some things you might see in this person could be polyuria, nausea, vomiting, thirst, constipation, kidney stones, pathologic fractures, because with the increase in the calcium, they could develop bone cysts and a thinning of the bones, which increases their risk for pathologic fractures. So to take care of this, you want patient education on drinking plenty of fluids. You want to have plenty of fluids um, to try to, flush that out. Um, severe cases, they may do some IV fluids, so you want to monitor their ionos uh, and possible hemodialysis depending on the severity of it. Prevent stress and strain on the bones because, like I said, they're at risk for pathologic fractures. Um, Parathyroid removal could be, needed as well. And so remember, because we said hyperparathyroidism because the parathyroid helps secrete calcium into the blood. Okay, so we said magnesium helps with nerve impulses, transmission, um, muscle contraction, things like that. So a normal magnesium is 1.3 to 2.1, and so hypomagnesium would be magnesium level less than 1.3, and hypermagnesium would be a magnesium level greater than 2.1. Some things that can cause hypomagnesium might be malnutrition, alcoholism, diuretic use, the thiazide diuretic, um, extensive gastric suctioning or diarrhea, certain antibiotics, vomiting, polyuria, things like that. So some things you might see in this patient. Again, you could see that Chebystek's sign, which we saw in the calcium, because the magnesium also helps the body to absorb and retain calcium. So you would see the hypocalcemia. So all those signs and symptoms of hypocalcemia you could see as well. Um, so the Chebystek sign where you're tapping along the side of the face and you get the muscle twitching. So muscle twitching, you could have the cramps, the tremors, the seizures, um, AFib, anorexia, nausea, vomiting, confusion, memory loss, hyper reactive reflexes, things like that. So hypermagnesium, um, now that one occurs with renal failure or overtreatment of um, overtreatment of, like, if you're treating hypomagnesium and you overtreat them, then you could cause the opposite problem of hypermagnesium. Magnesium. Overuse of magnesium laxatives, could also cause hypermagnesium. So things you might see could be diarrhea, hypotension, nausea, vomiting, um, respiratory depression, uh, changes in their EKG, sweating, weakness, bradycardia, which is decreased heart rate less than 60, decreased deep tendon reflexes, hallucination in severe cases, coma in severe cases as well. So things we're going to do for them, we're going to check their vitals and reflexes regularly, monitor their neurologic status, and educate the patient um, against excessive use of laxatives and antacids. Okay, so the phosphate, remember, we said helps with ATP production, and the ATP stores and transport the chemical energy within the cells. So a normal phosphate is 2.7 to 4.5. So phosphate less than 2.7 would be hypophosphatemia, and phosphate greater than 4.5 would be hyperphosphatemia. Things that can cause hypophosphatemia. If you have a person in DKA, diabetic ketoacidosis, respiratory alkalosis, sepsis, um, malabsorption disorders, overuse of aluminum-based antacids, hyperparathyroidism, vitamin D deficiency, alcoholism, severe burns, anorexia, things like that. So some things you might see in this person: confusion, seizures, muscle weakness, respiratory distress, pale skin, um, so things like that, things that you would do for the person. Obviously, we're going to do some patient teaching on foods containing phosphorus and food preparation to minimize phosphorus loss, monitor the respiratory status, monitor for bleeding, implement measures to protect against infection. IV phosphate might be ordered, administer it slowly, and don't infuse with calcium. So hyperphosphatemia, so greater than phosphate greater than 4.5, things that might cause that: people with renal failure, hypoparathyroidism, excess intake of laxatives, enemas, things like that, um, prolonged exercise, chemotherapy, respiratory acidosis, calcium or magnesium deficiencies, increase of vitamin D levels. And so you might see numbness, tingling in the person, muscle spasms, tetany, seizures, tachycardia, anorexia, nausea, vomiting, diarrhea. And so you want to educate the patient on excessive intake of foods containing phosphorus. So make sure they read the labels and things like that. Monitor their vitals, monitor their reflexes, monitor their urine output, and so administer calcium as ordered as well. So question 1, Kimberly's patient is on strict intake and output measurements. Her patient's total output is 2,200 mLs. What should be the total? What should the total be for an average adult? So the answer is 2,400. 2,400. If Kimberly's patient has an output of 2,200 mLs. Question 3. Amanda's patient is going home from the hospital. Her patient has a history of congestive heart failure. She includes in her discharge teaching for the patient to weigh herself. So your answer is going to be 2 in the morning with the same scale and same clothes. So remember, we said you want to measure the person every morning before they eat, after they urinate, wearing the same amount of clothes, using the same scale to get an accurate weight. Question 4. After Amanda's patient goes home, she notices her rings are tighter around her fingers. She has gained 5 pounds in 2 days. She is experiencing fluid overload. In fluid overload, a patient's vital sign changes. Which of the following might be anticipated regarding the blood pressure? The answer is 1, a rise in systolic blood pressure. So fluid overload will cause a rise in the systolic blood pressure. A bounding pulse is also associated. Um, and fluid volume overload. Okay, so proper acid-base balance is critical to life. Too much of either can disrupt the delicate homeostatic environment required by the body to perform life-sustaining functions, and a margin of error to either side is very narrow. And so, fortunately, under normal circumstances, the body is able to maintain the required level of balance. An acid is defined as any chemical that releases a hydrogen ion in the solution. So when acids are placed in water, they release hydrogen ions, which cause the water to become more acidic. Some acids can be very strong, such as hydrogen chloride. A base is defined as any substance that can accept hydrogen ions. A base is also called alkali. So similar to acids, bases can be either strong or weak. And so then we have, our pH. The amount of acid or base in a solution is represented by the pH. So a pH can range anywhere from 1 to 14, with 1 being extremely acidic and 14 representing a strong base or being very alkalitic. The normal pH of the blood is 7.35 to 7.45 is the normal pH for the blood. And so if the pH in the blood is less than 6.8 or greater than 7.8, death can occur. But there are some areas in our body that are naturally more acidic. For example, our urine is naturally more on the acidic side. Our gastric contents are naturally more on the acidic side. But when we're talking about the pH in the blood, our normal range there is 7.35 to 7.45. So anything less than 7.35 is considered acidic. Anything more than 7.45 is considered alkalitic. So the bicarbonate neutralizes excess acids in the body, and a normal bicarbonate is 22 to 26. So if you have a decrease in your bicarbonate, that can lead to acidosis, and an increase in the bicarbonate can lead to alkalosis. And it's represented by HCO3 is your bicarbonate. So three things are included when determining a person's ABGs, arterial blood gases. The pH, in which I said a normal pH was 7.35 to 7.45. The bicarbonate or the HCO3, which is 22 to 26. And then the CO2, which is 35 to 45. So if you have a decrease in your pH below 7.35, that is considered acidic. And an increase in the pH above 7.45 is going to be alkalitic. Same thing with the bicarbonate, the HCO3. If you have a decrease below 22, that will be acidic. And then an increase will be above 26 will be considered alkalitic. And the CO2 is opposite. So the CO2, if you have a decrease in the CO2 below 35, is going to be alkalitic, and an increase in the CO2 above 45 is going to be considered acidic. So if the issue is with your CO2, it's going to be a respiratory issue. And if the issue is with your bicarbonate or your HCO3, it's going to be a metabolic issue. So a person experiencing respiratory acidosis will have a pH less than 7.35 and a CO2 greater than 45. Because remember I said if the issue is with the CO2, then it's going to be a respiratory issue. So things that cause respiratory acidosis are going to be things that block the exchange of the CO2 and the O2 in the lungs. And so things that block that exchange will cause the CO2 to build up. So things that block the exchange of CO2 and O2 could be like pneumonia, airway, some type of airway obstruction, COPD, chronic obstructive pulmonary disease, um, chest injuries, excessive opioid intake, things like that will cause respiratory acidosis because they're blocking the exchange of the CO2 and the O2. Okay, so the person, they could be, experiencing chest pain, abdominal pain, muscle weakness, nausea, vomiting, things like that as well. But those type things will block the exchange. So whatever symptoms you might see with pneumonia, asthma, COPD, airway obstructions, things like that. So they may need bronchodilators. They may need surgical interventions depending on if it's some type of chest injury or something like that. So people with metabolic acidosis. So metabolic acidosis. So anytime you see acidosis, you know that pH is going to be less than 7.35. And remember, I said if the issue is with the bicarb, it's when it's going to be metabolic. So a bicarbonate level less than 22 will be metabolic acidosis. So things that's going to cause you to have metabolic acidosis would be like DKA, diabetic ketoacidosis, or if a person's in kidney failure or something like that, those individuals are going to uh, be in metabolic acidosis. So people with respiratory alkalosis will have a pH greater than 7.45 and a CO2 below 35. So things that can make your CO2 decrease basically is hyperventilation. And so hyperventilation, that could be caused by anxiety or also something else that can cause respiratory alkalosis is overuse of aspirin as well, or hypoxemia. But pretty much your hyperventilation is going to be the issue of your respiratory um, alkalosis. Okay. Okay, so metabolic alkalosis. Metabolic alkalosis, they're going to have a pH greater than 7.45 and a bicarbonate or HCO3 greater than 26. And so things that can cause this, so think about things that make the gastric area uh, not acidic because we said the gastric contents are very acidic. So vomiting takes all the acid out. Excessive gastric suctioning can cause that. Excessive use or abuse of antacids can cause metabolic alkalosis. Also, diuretic therapy or potassium deficit can cause metabolic alkalosis. All right, question 5. Terry's patient is critical. She has poor circulation, uncontrolled diabetes, a history of renal failure, and diarrhea. She is at high risk for which acid-base imbalance? So the answer here is going to be number 2, metabolic acidosis. So Terry's patient is at high risk for developing metabolic acidosis. So remember we said diabetic ketoacidosis or renal failure would be metabolic acidosis, and a person with uncontrolled diabetes has the risk of going into DKA, diabetic ketoacidosis, plus this patient has renal failure as well.